Hello everybody and welcome to the final day of our course. Today it's all going to be about the skin, the eyelids, the conj and the cornea. And we're starting off today with a talk from, she says, looking here, from Mark. So I have this feeling that Mark couldn't make it today. Let's start going, have we got Zia here?
Let me stretch out.
Yes, I'm here.
Would you like to go first then?
Yep, I can go first.
And then if Mark isn't here after you've finished, I will talk about what's commonly asked in skin, eyelid and conjunctiva.
Okay, so I just share my screen, is that right?
Yep, you share your screen if you go.
Great, and where is my present thing? Great, so my questions were on the secondary effect of trauma and radiation, and that is related to one of the curriculum areas. You know how they have like the standards and then the areas underneath, and that is on wound healing and trauma, and they're talking about healing and repair in ocular orbital and periocular tissues, and also modulation of wound healing, trauma, and the shrunken eye. And the specific entities that were commonly asked were blunt trauma, intraocular foreign bodies, chemical injuries, radiation, and phthisis. And they all came up quite a lot. They've all been asked about 4 times. So I guess that'd be the ones to focus on. And so I've gone through each one to describe what specific tasks were asked in each one. And so for blunt trauma, they asked about the macroscopic and microscopic features and also the late complications. For intraocular foreign body, again, they also talk about short and long-term complications, and were often specifically related to iron and organic material foreign bodies. For chemical injuries, they just have like repeated quite generic questions of the effect of chemical trauma on the eye. So they didn't specifically state whether it was like an alkali injury or anything. They just say pretty broadly about chemical injuries in general, which I thought was a bit interesting. Radiation came up a lot. And the main topics they focused on were the pathological effects and the ocular complications, including the pathogenesis of them, the histopathologic findings, and also the microscopic features. And then in phthisis, they talked about the microscopic and macroscopic features, the specific processes, including calcification, bone formation, and gliosis, and also emphasized difficulties for the pathologist when receiving these kinds of tissues or samples. The question I did, and I just have to minimize that one so I can actually see it, was a question about radiation, and it was a patient with a posterior choroidal melanoma that has plaque radiotherapy. What are the clinical and histopathological features that would be seen in the eye 6 months post radiotherapy? And with this question, I found 2 things kind of difficult to, when I was answering it. I wasn't quite sure, like when they were meaning what you would expect to find 6 months later, whether they were talking about normal changes or whether they were talking about like complications of that could occur following the plaque. And then how specific they were wanting you to be like to the location. And the examiner's comments, they said specifically that a big mistake was that people weren't specific to the posterior plaque and just kind of generally rambled off the effects of radiation. But then I kind of didn't know how specific they wanted you to be. And then they also mentioned about not talking about the clinical and pathological effects. So I imagine that means a lot of people may have missed out the clinical things, which is sometimes kind of easy to do. And they also said, don't describe the melanoma before the radiotherapy. And again, I guess that's just that point that they're specifically asking you for the effects of radiation, not a question on choroidal melanoma itself. And I guess the only reason they've put the choroidal melanoma in there is so that you think about the region and then what would be specific to that area. But again, just in, oh yes. Oh, sorry. But then just that point about not really knowing how much they meant about the normal and complications, when I answered it, sorry, I just said first kind of what you would expect to find in the area of the retina where they had the plaque, and then the possible complications that could occur around that, I guess. And so I'd be interested to hear what you guys would say about what they're actually asking for. And so my top tips were effective radiation is a common question, so it's good to know that. They often ask for both the clinical and the histopathological features with the trauma, so it's important not to forget to actually describe the clinical stuff, even though it's quite straightforward because that's what we see all the time. And then there were some specific examples like the type of intraocular foreign body, and most questions also focused on the late complications. And I guess then just that other important tip about talking about phthisis, always mentioning that it's a difficult sample for the pathologists to review. And that's all.
That's really great, Zia. So one of the messages I'm getting out of this is that when answering these kind of questions, you need to think about the framework that you're going to answer them in. And when people ask about clinical and histopathologic features, often in these questions, when they mean by clinical, they mean like what you see. And I'm holding up an imaginary ophthalmoscope here, but probably you're more likely to use other instruments these days. So the clinical is what I would call macroscopic. It's what you see clinically, as well as the histopathology. And one of the things that makes these questions easier for you guys is you do see them all the time. So a good framework in answering pathology questions is always going from macro to micro to clinical to histopathologic. And then you've got to think about other kind of structural frameworks you could use. If you were just asked a general question about radiation, you know, a good framework is a timeline thing, acute through to chronic. And then if you were asked a specific site, then general through to specific would be another good framework. So I think it's analyzing the question. Can we go back to sharing your screen and looking actually at that question, and we'll do that exercise together, and we'll think about the best way to answer this question, because it is a high frequency question, is radiation. Would you share your screen again, Zia?
Yeah. I'll just
okay, so posterior choroidal, what are the clinical and histopathologic features that will be seen in the eye 6 months post radiotherapy? So the timeline is well defined, 6 months post. Yeah. And they want you to go what you would see with your in clinic and the associated histopathologic features, which is a relatively straightforward question. And so the framework we're going to use is general through to specific. You are asking what's normal and what's a complication. So from my perspective in this question, anything would be up for it. So you might think it would be normal that you would get melanoma lysis, or it might be normal that you would get some retinal, atrophy, but they are asking for everything.
Yeah.
So you might want to divide it into, for example, effects on the melanoma, effects on the retina, or effects on the optic nerve, effects on different structural components at a specific point in time. Yeah, that would be how I would answer it.
Cool. Thank you.
Any other comments from people?
Sorry, given the timeline of 6 months, would it be wrong if you said things like cataract or potential tumor recurrence or NVG, or is that more long term?
So that's a clinical question. And does cataract happen after 6 months?
Well, I put cataract.
It could, I guess.
Yeah.
Yeah. So because I don't see patients 6 months after having radiotherapy, you guys know what you see.
Yeah.
Okay. Some other questions. So it is another really common question to ask about wound healing around trabeculectomies and around corneal incisions and stuff, and particularly how they're modified using drugs, and how those work. So I would also think about that too. That's often asked in the part A, and the plaque things often asked in the part B. Good. Any other comments from people?
Well, that was really good. Thanks, Zia.
That was really helpful. Thea, do you know how to upload your presentation?
No.
Amanda, would you like to demonstrate?
Well, I see that Zia's got a Google slide, so that's even better because it will blend with our classroom, I think. So if I just share screen, let's see if we can do that. I just want to share the Google Classroom screen, just a moment. Let's see if we can do that. You are screen sharing. What am I screen sharing? Everything?
Yeah, we can see everything.
Oh, okay.
Sunset on the Kaipara.
Yeah, no fishing today.
I think I should be able to get it. Do you just do create and add it into the classroom?
Yeah, that's what you do. That's exactly what you do.
Yes.
Yeah.
I think we'll recommend people do a Google slide in the future. It'll be easier than converting from a PowerPoint.
Okay.
Are shareable.
So Mark isn't here, is that right? So I will talk about common questions and tasks in skin, eyelid, and conjunctiva. So I think I want to talk about the common tasks first. So this is a task sometimes where we're asked to describe the histology, and we need to know the important keywords between benign and malignant. So do you remember how when you were doing the Cura Cloud, I gave you a formula where you looked at the low power, how to describe a slide. Low power, then high power, check if it's benign or malignant, talk about the specific types of cells seen. Yeah, that's the kind of formula that you need to use when you're being asked about how to describe an entity. Okay, so the clinical / macro / micro is a common question, tasks that's used. So for each of these entities, have your keywords ready. Clinically, they present as, microscopically, move from low power to high power, and then the specific features that tell you benign or malignant, and then the things that you would check out if you were normally looking at a slide to see, confirm what cell type it is. So the entities that I think you need to know are, it's quite a long list, but they're overlapping a bit between the skin and the conj. So we can like double dip on them. So for the skin, I think you need to know squamous lesions, and the squamous lesions I think you need to know are SCC and papillomas. Sorry, I've just gone blank here. Not keratoacanthoma.
Melanocytic things.
Yeah, sorry. I was just thinking of the squamous lesion. Oh, man. Seborrheic keratosis. Why could I not remember seborrheic keratosis? Okay, squamous cell carcinoma, squamous papillomas, seborrheic keratosis, and then basal cell carcinoma. So they're all the kind of the epithelial things. The melanocytic things, nevi and melanoma. And then there's the skin adnexal things. You need to know sebaceous adenoma and sebaceous carcinoma. And then the inflammatory things, you need to know chalazion and particularly the bullous skin diseases. And for the bullous skin diseases, you need to know how to send them to the lab as well. In conj, we've got the in situ squamous lesions, pterygium, the invasive squamous lesions, mucoepidermoid carcinoma probably, and the melanocytic lesions, both in situ and invasive. And in the inflammatory lesions in the conj, probably you need to know amyloid. They love amyloid. Can you think of anything else, Amanda?
It's just like the chapter headings in the
Really is,
Eagle.
yeah.
And I see Mark's in the room now.
Mark.
Mark's here. He's woken up and he's in front of the screen.
We're talking about your question about the things you need to know in the eye.
Oh, yeah. Do you want me to share my PowerPoint?
Yes, excellent.
I'll just give me 2 minutes. I'll load it up on this computer I'm using Zoom on.
Yeah, so yeah, the chapter headings are good. And then we move on to the cornea where there's the various degenerations and dystrophies and inflammations and infections. So again, I'm going to emphasize it's a bit about structuring your answer, moving from low to high power.
And then sequentially through the anatomy of wherever you are.
Yeah.
Makes it easier. Front to back, anterior to posterior, inside to outside, whatever it is. Right, Mark. Not sharing yet.
Oh, yeah, just.
It is early for you, Mark.
It's that extra half hour before the East Coast. Just tough. All right, share screen. Is that visible?
Yes, great.
So my topic was skin, conjunctiva and eyelids, as we've been talking about. So the commonly asked questions and the rarely asked questions. Going back through the past exams that I had access to, BCC and SCC come up again and again. So do sebaceous gland carcinomas. There's a mixture of questions on sebaceous, both as sort of a chronic chalazion and as chronic blepharoconjunctivitis in an older patient, as well as some questions that come back the other way from the histology of SGC. So that one's a good one also. And then melanoma, and as you mentioned, differentials for pigmented lesions does come up a bit also. I felt that the solar keratoses, the Merkel cell tumours and the cysts were quite uncommon. And I actually just sort of reflecting on your comment there, Dan, about papillomas. I didn't see too many questions in the resources I had about papilloma, but my past questions only got up to sort of 2015. Then in the conjunctiva, OSSN comes up something like 7 times on my count, and then trachoma was 3 times. So it's far and away the most favourite question about the conjunctiva. And although there are a couple on pigmented lesions in their differentials, say of acquired melanosis, they're not that common. And certainly cicatricial pemphigoid, again, sebaceous gland carcinoma with pagetoid spread and atopic keratoconjunctivitis were both 1 question each, so quite uncommon. So I think the money there in terms of volume was BCC, SCC and OSSN. The tasks that are often asked on conj and eyelid was really all about pathogenesis and histological sections. The ones in bold and underlined are the task words that come up most often in the past exams that I was looking at. And they seem to focus on those more than any sort of explanation of the natural history of the disease, or, not very much about the clinical presentation necessarily about these eyelid lesions. There were a couple of questions as well that worked the other way. So these questions, instead of asking for the histological section, asked you to interpret a provided histological report. So they were asking you to make sense of what is a SIN2 lesion and what does it mean if the margins aren't clear, these sorts of things. And the differential diagnoses always came down to pigmented lesions, I thought. So I did a test question on OSSN, since it was the most frequently asked topic out of all of the questions that I looked at. And I think that the model answers for that provided in the resources for this course cover all of the main points that I'd previously read about. I just had two questions italicized there that we could talk about, or maybe talk about later. I just couldn't remember exactly what we had said macroscopic means in these questions, whether it just means the clinical appearance or whether it means also the macroscopic appearance of the section that they cut out. I don't know if either of you wanted to comment on that now, or...
So the macroscopic appearance that we see when we look at the ellipse of tissue on the cut-up board is the same as you would see looking at the patient.
Mm-hmm. Okay.
So it's the same thing, but of course it's much easier for you to describe it seeing it in the patient, because you do that.
Yeah.
So naked eye looking at the patient. You know, the pearly papule, that sort of thing, the crusty lesion.
Yeah. And then there are just sort of thinking about this question, which was a describe question, and there are also a number of questions that are using the task word list. You know, if you get given a describe question, should you be avoiding dot points? Are they that specific? Do you think about the distinction between describing and listing features of a disease, or is it all much of a muchness?
Yeah, so describe, please use dot points.
Still use dot points as well? Yeah.
Yeah, so, but the dot points have sentences past them, and they're arranged in under headings. So macroscopic, microscopic, 3 dot points, 3 sentences to describe 3 important things.
Yeah.
Just think about how easy it is going to be to mark. Like there's so many marks assigned to that question. Make it easy for the marker to identify you've got 3 points out of it.
Okay. No block text. I thought, just sort of reflecting on the answer to this question, that, you know, the clinical term of OSSN obviously then encompasses quite a broad spectrum of histopathological disease, and you can't say what is what until you cut it out and look at it under a microscope, and then the term OSSN no longer applies. And I thought that was just an important point to remember. And then I also thought that, as well as commenting on, you know, the malignant cell type and how it invades 2/3 of the conj in SIN2 or whatever you might be describing, you know, there were also some dot points in there about commenting on the other features, such as loss of goblet cells or loss of polarity of the cells, just those additional things that happen in the conj in the disease. So I think really the top points are, can you look down a microscope and distinguish basal cell, squamous cell, and sebaceous gland carcinomas? Because that seems to be a common point that is touched on. And then knowing about OSSN and understanding the distinction between SIN and invasive squamous cell, I thought was also a very common question or common point.
One thing I think that's going to become more common is talking about the genetics, particularly in melanocytic and sebaceous lesions. So it's really important that you're able to, for example, talk about the genetics of conj and skin melanomas, which have the same genetics and are driven by essentially BRAF mutations or NRAS mutations, but mutations in the tyrosine kinase pathway, because tyrosine kinase inhibitors are now commonly used to treat these diseases when they are when they've metastasized, and realize that there are some other specific genetic conditions that relate to lesions around the eye. So I'm thinking of sebaceous adenoma and Lynch syndrome, and multiple BCCs and Gorman's syndrome. Can you think of any others, Amanda?
Muatore, I guess that comes under the Lynch.
Yeah, Muatore is the variation of Lynch syndrome that gets the multiple sebaceous adenomas. Yeah.
Maybe you could even, because when we're thinking about Lynch syndromes, there's special stains that can be applied, and we do these routinely now for microsatellite instability.
Yeah, we do. So every time we have a so do you do them on sebaceous carcinomas as well?
Any sebaceous lesion.
Any sebaceous lesion, yeah, any sebaceous lesion. I do it too, looking for Lynch syndrome. So does anyone know the stains that we do? The DNA mismatch repair stains. So that's an important phrase I think that you need to know. So Lynch syndrome is a abnormality in DNA mismatch repair, and the stains we do are, I don't know, do they need to know the names of them, do you think, Amanda?
Probably the category microsatellite instability, because you could also do it by other mechanisms, not just immunohistochemistry.
Yeah.
But I'll just write this in.
We do immunohistochemistry. So they're probably a bit confused now about the difference between microsatellite instability and DNA mismatch repair.
Okay. Okay, that's a homework thing to look up. So there we go.
I can post something about that.
We'll get a resource for that.
Yeah, but they're the same thing.
Yeah.
Okay, I've got a question in the chat here. Oh yeah, yeah, that's you putting it in. Okay, should we start to look at some slides?
Yes.
Okay, so if we go to our Google sheet here, that tells us what we're going to do. I will pop you into breakout groups of 2 again, and we'll look at the first slide. Now I'm only going to give you 5 minutes here because it's a easy, straightforward slide. So off we go into our breakout rooms. And how many have we got here?
We've got how many? 12 participants, so we need 6 rooms.
6 rooms. Okay, off we go.
Dive into the rooms.
Jess, looks like we're together here. No, you've not joined. You've not joined Mark yet. You having slight trouble there? Oh.
Hi, I'm my internet's gone really dodgy.
Okay. Moaz, are you having trouble joining a room as well?
I was by myself. So
All right, I'm going to put you in. You're by yourself. Okay.
in that room.
I'm going to move you to join Mark because, okay. All right, no, that's okay. Now Jess has gone in with Mark, so you get to go and explain the slide to me. How about that?
Oh, that's okay. Just do that.
I'll like click on the slide there and drive.
I didn't. Oh, should I just share my screen?
Yeah.
Or should we go to a room?
No, you can just share your screen. That's fine.
Can you see my screen?
I can see your screen.
So